Welcome to the Deep Dive. We're the show that really tries to cut through the noise and get to the core insights on complex topics. Today, we're jumping into something really critical and honestly often quite heartbreaking in the world of newborn horses: neonatal full septic arthritis and septicemia. Our mission here in this deep dive is to give you the essential knowledge, those aha moments, based on a whole stack of sources we've gone through. We're going to cover, how these little guys get infected, what the latest treatments look like, and maybe most importantly, prevention. How do
Yeah.
we stop it?
And this isn't just another medical issue on a list. For a newborn foal, this is, well, it's a rapidly escalating internal disaster. It's a genuine medical emergency. The consequences can be huge, often life-altering, not just for the foal right now, but for its whole future. Understanding it is absolutely key.
Okay, so let's start right there. What is neonatal full septic arthritis? You sometimes hear it called infected joint or maybe joint ill. But the key thing, I think, is realizing that while joint ill might sound simple, in a newborn foal, we're talking about a serious bacterial infection setting up shop inside one or more joints. And prevalence-wise, it's not super rare, is it? Affects maybe 0.5% to 1% of all foals born.
That's right, around that mark. And the consequences, well, they're anything but simple. You're looking at potential chronic lameness, maybe permanent loss of joint function. We even see issues like laminitis, the opposite limb, if the foal makes it to maturity. And in the really severe cases, tragically, it can be fatal. What's also fascinating here, maybe in a grim way, is the economic side, the cost. Think about long hospital stays, multiple anesthetics for joint flushing, long courses of antibiotics, maybe even arthroscopic surgery. It adds up to a really substantial financial hit for the owners.
Yeah, that financial strain is definitely part of it. But what really hits home for me is how it can just completely derail a foal's future potential. Foals treated for this, even if they recover fully from the infection itself, often take way longer to start a racing career. And kind of astonishingly, only about half might ever actually race, even if the infection is totally gone.
Right. And if multiple joints are involved, the racing prognosis gets even worse.
Which, for an industry built on athletic potential, that's a huge loss. It really impacts the bottom line, that potential return on investment. So how does this happen? How do these tiny foals, who seem pretty robust, get such a devastating infection to begin with? What are the root causes?
Well, the number one way is through something called hematogenous spread. Basically, bacteria from somewhere else in the foal's body, like the gut or lungs, get into the bloodstream. And then the bloodstream carries them, like a delivery service, right to the joints.
Okay, but why the joints? Why are they the destination? You'd think they'd be sort of protected.
That's a really good question. It comes down to the unique anatomy of a foal's developing joints. They have these specialized tiny blood vessels and loops of capillaries and these things called metaphyseal vascular loops near the growth plates. And in these specific areas, the blood flow is actually quite sluggish. It slows right down.
Ah, like a little bottleneck.
Exactly. It creates this perfect environment, almost like a sink, where bacteria floating by can easily settle out and start multiplying. So even a temporary presence of bacteria in the blood, what we call bacteremia, which might not cause issues elsewhere, can lead to a full-blown infection right there in the joint.
Wow. So the way their body is built at that stage actually makes them vulnerable. Are there other ways infection can get in besides traveling through the blood?
Oh, absolutely. You can get direct inoculation. Think of a puncture wound directly into the joint.
Yeah.
Or an infection in tissues right next to the joint might just spread across. And then, unfortunately, sometimes it's iatrogenic, meaning it's related to a medical procedure, like contamination during a joint injection or maybe a post-surgical infection.
That sounds incredibly challenging for vets. Even with extreme care, it can still happen.
The constant challenge, yeah.
Mhm.
Even with the most careful aseptic techniques, using sterile procedures and maybe prophylactic antibiotics, it's hard to eliminate the risk completely. Things like microscopic hair contamination during an injection can occur. And interestingly, routine antibiotics given around surgery haven't consistently lowered infection rates in horses. It really shows how difficult perfect prevention is in the real world. We do our best, but
Yeah. Okay, so if bacteria are getting into the bloodstream first, where are the main entry points? What are the weak spots?
the big ones are usually the gastrointestinal tract, the gut, the respiratory tract, and a really significant one for newborns, the umbilicus. That umbilical stump, right after birth, it's basically an open pathway, an open wound.
Right, a direct line in.
Exactly. And if the foaling environment isn't clean or if that stump isn't cared for properly with disinfectants, it's a major risk. It can lead straight to septic arthritis or even things like pneumonia. Serious life-threatening stuff.
And do we know which specific bacteria are the usual suspects here?
Yeah, we have a pretty good idea of the common culprits. On the gram-negative side, Escherichia coli, E. coli, is often the most common, especially in really young foals, which points back to that gut connection.
Hmm.
Others include Klebsiella, Pseudomonas, Salmonella species, Enterobacter, Actinobacillus, quite a few. Then for gram-positive, Streptococcus species are very common. And we're actually seeing more Enterococcus species lately, Staphylococcus too. And occasionally you'll find Rhodococcus equi, especially if there's lung involvement too.
Hearing E. coli and other gut bacteria come up so often really seems to highlight the gut's role, doesn't it? It's not just about the joint itself.
That's a key insight, absolutely. The fact that we consistently find these gut-associated gram-negative bacteria in infected joints strongly suggests the gut is a major source, a reservoir. It really underscores how vital intestinal barrier integrity is. The gut wall keeping bacteria in the gut where they belong and maintaining a balanced gut microbiome. If that barrier breaks down, bacteria can basically leak out or translocate into the bloodstream, and then it's an easy trip to those susceptible joints. So yeah, gut health is surprisingly linked to joint health in these cases.
Okay, beyond the routes of entry and the specific bugs, what else makes one foal more likely to get this than another? Are there predisposing factors?
The single most critical predisposing factor is failure of passive transfer. FPT foals are born immunologically naive. Their own immune system is brand new, hasn't seen much. They're utterly dependent on getting maternal antibodies from their dam's colostrum, that first milk.
That liquid gold.
Exactly. If they don't drink enough good quality colostrum, or if they don't absorb it properly within that crucial first 24 hours, they just don't have the defenses. They're wide open to systemic infections that then often settle in the joints.
And it's not just about missing the antibodies themselves.
No, it's more than that. Their neutrophil function, neutrophils are key infection-fighting white blood cells. That function is also weaker if they have FPT. Things that lead to FPT include, the mare dripping milk before foaling, the foal being slow to get up and nurse, maybe the colostrum itself isn't good quality, or the foal has gut issues affecting absorption. And the stats are pretty sobering. About a quarter of foals with severe sepsis develop septic arthritis. And foals with FPT are almost twice as likely to get septic arthritis or osteomyelitis, which is bone infection.
Wow, that's a huge risk factor. What else puts them at risk?
Well, even if a foal does get adequate passive transfer, their own immune system is still immature. Neonatal neutrophils, they just don't move towards infection as well. That's called chemotaxis, and they're not as good at killing bacteria. Their T cells, another immune cell type, are naive. They haven't learned to recognize many threats yet. So there's this baseline vulnerability. Then you have environmental and management factors. Obviously, unsanitary foaling areas or poor umbilical care. That's
Seems basic, but critical.
absolutely critical. Overcrowding, having too many foals in one area, that increases the bacterial challenge. And finally, septic arthritis often doesn't happen in isolation. It's frequently a consequence, a sequela, of a broader systemic infection, sepsis. It can go hand in hand with pneumonia or enteritis, umbilical infections like omphalocolitis, even meningitis. And it often occurs alongside osteomyelitis, the bone infection we mentioned, or septic fasciitis, which is an infection of the growth plate. So seeing septic arthritis can be a big red flag that there's a much larger systemic problem brewing.
Spotting the signs when a foal is sick. It sounds like it can be really tough, especially if it's not just a dramatically swollen joint. What should people be looking for?
Yeah, early detection is everything, and it can be tricky. For the localized signs in the joint itself, you're looking for effusion, which is swelling. Lameness is key, and it might be really sudden, like they just won't put any weight on it at all. You might also feel pain if you gently palpate the joint, and it might feel warmer than the surrounding area.
But I've heard that lameness especially can be really subtle in foals, or maybe not even there. Is that right?
That's absolutely true, and it's a major challenge. Lameness can be incredibly subtle or even absent, especially in foals that are already weak or lying down a lot because of the systemic illness. Sometimes people might think, oh, the mare accidentally stepped on its leg, when actually it's a serious infection brewing inside. The joints most commonly hit are the hock, stifle, fetlock, and carpus or knee. So because it can be so subtle, meticulous, twice daily palpation of all the joints in any at-risk foal is just crucial, feeling for even slight swelling or pain. You have to be proactive.
Okay, so beyond the joint itself, what about the systemic signs, the signs of that broader sepsis? You mentioned they can be vague.
They really can be very nonspecific. Things like depression, lethargy, just not being bright and active, a decreased or maybe even absent suckling reflex, which can progress to them just lying down, being recumbent. Their temperature can be all over the place. Fever is common, sure, But in advanced sepsis, they can actually become hypothermic, have a low temperature, which is really misleading and a very bad sign. Other clues might be a fast heart rate, fast breathing, maybe their gums look really red, injected, with a fast capillary refill time. Sometimes tiny pinpoint bruises called petechiae. Diarrhea is also common. But yeah, they're hard to pin down because any one of those could be something else in a young foal.
So just a quick glance isn't going to cut it then.
Definitely not. Relying only on just observing them casually can mean you miss crucial early signs and delay diagnosis. A full diagnostic workup is often needed to really figure out if sepsis is involved, because those initial signs are just too easy to overlook or misinterpret. We can't afford that delay.
And it's also important to tell septic arthritis apart from other things that might cause joint swelling or lameness, right?
Precisely. A swollen joint doesn't automatically mean infection. For instance, septic cystitis infection of the growth plate might cause swelling over the growth plate area rather than right in the joint capsule itself. And then there's non-septic fasciitis, which is usually seen in slightly older foals, maybe 3 to 6 months, and it's typically linked to nutrition, not infection. Septic arthritis, though, usually hits younger foals, under a month old typically, and it is infectious.
So how do you actually sort that out? How do you know for sure what you're dealing with and how bad it is?
That's where diagnostic imaging is absolutely vital. Radiographs or X-rays are essential to look for bone involvement, osteomyelitis, or septic cystitis. They can show us if the bone is being damaged or eggolytic areas. Ultrasound is also incredibly useful for seeing the joint fluid itself, assessing soft tissues around the joint. These tools help us differentiate infectious versus non-infectious causes, and critically, they tell us the extent of bone damage, which heavily impacts the prognosis and how we need to treat it. It gives us that visual proof.
All right, let's get into that diagnostic deep dive. You suspect septic arthritis. How do you confirm it? How do you really find out what's happening inside that foal?
Well, it always starts with the basics. A really thorough physical exam and getting a detailed history. And the history, you're digging into things like, did the mare leak colostrum? Was the foal slow to nurse? Anything suggesting that failure of passive transfer. And the exam needs to be meticulous, systematic, carefully feeling every joint, checking those systemic signs. Given how subtle it can be early on, you need a high index of suspicion.
Okay, history and exam done. What's the next crucial step? What gives you that direct look inside the joint?
The absolute cornerstone is analyzing the synovial fluid, the joint fluid itself. Just looking at it grossly with the naked eye tells you a lot. Normal fluid is clear, pale straw-colored, and really viscous, stringy, like egg white. Septic fluid is usually darker, cloudy, turbid, watery, and much less viscous. If the cell count is sky-high, it might even look totally opaque, like pus. These are quick, cheat clues right away.
And under the microscope, what does the cytology, the cell analysis reveal?
That's where you see the inflammation dramatically. A very high total nucleated cell count, way above normal. And it's overwhelmingly neutrophils, those immune cells, often over 80 or 90%. A key finding, indicating a really intense bacterial fight, is seeing degenerate and karyolytic neutrophils. These are cells that are basically dying and breaking apart in the battle. Finding a lot of those is actually associated with a poorer prognosis, unfortunately.
What about the chemistry of the fluid?
Biochemically, the total protein level in the fluid shoots up. And, very characteristically, the glucose level in the septic joint fluid is much lower than the glucose level in the foal's blood. Why? Because both the huge number of neutrophils fighting the infection and the bacteria themselves are gobbling up that glucose for energy. A significant difference between blood and joint fluid glucose is strong evidence for infection.
And finding the actual bug. You mentioned culture is the gold standard, but it has limits.
Right. Microbial culture and sensitivity testing, growing the bacteria and seeing what kills it, that's the gold standard. But, maybe surprisingly, the sensitivity isn't always great. We don't always manage to grow the bacteria. This can be due to low numbers of bacteria in the sample, or if the foal already got some antibiotics, or even because the high number of neutrophils can inhibit growth. Using a special blood culture medium to incubate the sample definitely improves our chances of getting a positive culture.
Are there faster ways to ID the bacteria, especially if culture fails?
Yes, thankfully. Advanced methods like PCR, polymerase chain reaction, are much faster and more sensitive. PCR can detect bacterial DNA even if the bacteria aren't alive anymore or are there in really tiny numbers. This can be a huge help for getting to targeted antibiotic therapy much sooner.
Okay, moving beyond the joint fluid itself, what about blood tests? What do they tell us about the bigger picture, the systemic response?
Blood work is critical for assessing the whole foal. A complete blood count, the CBC, can show different patterns. Early on, in overwhelming infection, you might actually see a low white blood cell count, specifically low neutrophils neutropenia. In slightly older foals, or as the body responds, you might see the opposite high neutrophils, neutrophilia. A key sign of severe sepsis is a degenerative left shift with toxic changes in the neutrophils. That means the bone marrow is frantically pumping out immature, stressed-out white blood cells to fight. Acute phase proteins are also incredibly useful, things like fibrinogen and especially serum amyloid A SAA.
SAA comes up a lot. Why is it so important?
SAA is considered the major acute phase protein in horses. Its levels shoot up very quickly in response to inflammation or infection, and they also drop quickly as things improve. So high SAA is very suggestive of infection, and because it changes fast, it's fantastic for monitoring treatment response. Are the antibiotics working? We can track SAA levels. It also helps with antimicrobial stewardship, deciding when it might be safe to stop antibiotics.
And checking that passive transfer status you mentioned, how's that done?
That's done by measuring immunoglobulin G, or IgG, levels in the foal's blood. It directly assesses whether they got enough antibodies from the colostrum. Very low levels mean complete FPT. Levels below about 800 milli-GDL are generally considered inadequate. But it's important to remember, IgG level alone isn't the whole story. You interpret it alongside other signs like SAA because a foal could have okay IgG but still be very susceptible if their own immune system is weak.
Any other important clues from a blood chemistry panel?
Definitely. The serum chemistry often shows signs of systemic distress and organ problems. You might see electrolyte imbalances, low sodium, chloride, potassium, metabolic acidosis, the blood being too acidic, signs of kidney trouble like azotemia, maybe high liver enzymes like GGT, or muscle enzymes like CK. These all paint a picture of how badly the foal's systems are being affected and guide supportive care. They need close monitoring and correction. When we talk imaging, ultrasound is great for looking at the fluid and soft tissues and guiding where to put a needle. It's also really critical for checking those internal umbilical structures, the veins and arteries in the stump for infection or abscesses, because often there's nothing obvious to see on the outside. For really tough cases, or when we suspect bone involvement isn't responding, advanced imaging like CT or MRI can be invaluable. MRI is excellent for looking at cartilage damage, but CT is often preferred in foals. It gives better detail of bone, it's faster, meaning less anesthesia time, and the machine openings are usually bigger, allowing for whole-body scans if needed. This level of detail really helps refine the prognosis and plan any surgery precisely.
And you mentioned sepsis scoring systems earlier. How do they fit in?
Yes, sepsis scores are useful clinical tools. They basically combine points from the history, the clinical exam findings, and lab results to give an overall score predicting the likelihood of sepsis. They often use criteria similar to SIRS systemic inflammatory response syndrome, looking for things like abnormal temperature, abnormal white cell count, fast heart rate, fast breathing. Having at least two of those flags a high risk. It helps standardize assessment and can prompt earlier, more aggressive investigation and treatment, even when the picture isn't totally clear yet.
Okay, diagnosis confirmed. Now, the fight begins. This is an emergency, you said. Why is speed so absolutely vital in treatment?
Speed is everything. It truly is a medical emergency. Any delay in starting treatment allows that infection in the joint to cause rapid and often irreversible damage to the articular cartilage. That damage is what leads to long-term lameness and poor athletic outcome. So immediate aggressive treatment, starting with broad-spectrum antibiotics, even before you have culture results back, is absolutely crucial. Minutes matter.
What does that initial immediate antibiotic attack look like?
Systemic antibiotics are the first line, usually given intravenously. The initial choice is typically broad-spectrum, meaning it covers a wide range of likely bacteria. Common combinations might be a penicillin-type drug like ampicillin, or maybe a third-generation cephalosporin like ceftiofur, usually paired with an aminoglycoside. Amikacin is often preferred over gentamicin because it's thought to be a bit less tough on the kidneys, but you still use caution, especially if the foal has kidney issues. Certain antibiotics, like fluoroquinolones, are generally held back initially due to concerns about potential cartilage damage in growing foals. Then, once those culture and sensitivity results come back, hopefully, you tailor the antibiotic choice to specifically target the bacteria identified. That's key for effectiveness and reducing resistance.
And how long do they need these antibiotics?
Duration is usually long, several weeks at least. Minimum 2 weeks for just bacteria in the blood, but often much longer, especially if there's bone infection. Often treatment continues until clinical signs resolve and inflammatory markers like fibrinogen normalize. And a crucial point on stewardship. We don't give antibiotics prophylactically just because a foal has FPT, unless there's
Mhm.
documented infection. There's no proven benefit and it contributes to resistance. Use them when needed, wisely.
Besides flooding the system with antibiotics, you mentioned more targeted approaches delivering antibiotics right to the source.
It's exactly. Local therapy is a powerful adjunct. Intra-articular injections, injecting antibiotics directly into the infected joint, achieve incredibly high concentrations right where they're needed, much higher than systemic IV doses, and with less risk of systemic side effects. Usually done daily or every other day for several days. Then there's regional limb perfusion, or RLP. This is where you put a tourniquet on the limb above the infection and inject a high dose of antibiotic into a vein below the tourniquet. This effectively traps the antibiotic in that limb, bathing the joint and bone in extremely high concentrations. Very effective for deep infections or osteomyelitis.
And those antibiotic beads you mentioned, how do they work?
Right, antimicrobial impregnated beads. These are usually made of a special bone cement, PMMA, mixed with an antibiotic like gentamicin. They're surgically placed into the infected joint or bone defect. They then slowly release the antibiotic directly into the site over weeks or even months. This provides sustained local treatment, which is great for chronic bone infections or joints that don't have a lot of movement.
So antibiotics are key, but what about actually cleaning out the joint, getting rid of the pus and debris?
That's absolutely essential. Joint lavage, or flushing, is critical for physically removing the infectious material, the bacteria, the inflammatory cells, the debris. Needle lavage, using large needles to flush large volumes of sterile fluid like saline or lactated ringers through the joint, is the minimum standard for any infected joint. Sometimes DMSO is added to the lavage fluid. For more chronic or severe infections with lots of fibrin, that sticky inflammatory protein arthroscopic lavage is better. Using a small camera and instruments allows the surgeon to see inside, break down and remove fibrin clots thoroughly, maybe trim inflamed synovial lining, and debride damaged tissue.
Why is removing that fibrin so important?
Fibrin is problematic because it can form a scaffold or matrix that protects bacteria, creating a biofilm. This makes it harder for antibiotics and immune cells to reach them.
Yeah.
Physically removing that fibrin is crucial to disrupt biofilms and reduce the inflammatory burden. In the most severe, stubborn cases, an arthrotomy might be needed, basically opening the joint surgically for more aggressive cleaning and drainage, sometimes leaving drains in place.
And if the infection has actually gotten into the bone,
If osteomyelitis or septic fasciitis is confirmed, then surgical debridement is often necessary. This involves physically removing the infected, dead bone tissue. That dead tissue acts as a source, a nidus for persistent infection that antibiotics struggle to clear. Sometimes the infected growth plate, the fifus osculi, needs to be curetted or scraped clean. Using CT scans to guide this debridement surgically has shown pretty good results.
it's clear the infection itself needs aggressive treatment, but these foals are incredibly sick systemically. How do you support their overall health through this ordeal?
That comprehensive supportive care is just as vital as the antibiotics and lavage. You have to treat the whole foal. Pain management is huge, not just for welfare, but a painful foal won't nurse. We use NSAIDs like phenylbutazone or flunixin, but cautiously, watching closely for side effects like gastric ulcers or kidney damage, which these sick foals are prone to. Gastrointestinal protection is usually needed too because stress and NSAIDs make ulcers very common. So things like antacid meds or sucralfate are often given. Although it's interesting, this raises an important question because some sources suggest caution with routine acid suppressors. Septic foals might actually have a less acidic stomach environment already, and making it more alkaline could potentially encourage bacterial overgrowth. So it's a bit nuanced.
Okay, that's an interesting point. What about basic needs like fluids and nutrition?
Absolutely fundamental. Intravenous fluids, IV drips, are critical. To correct dehydration, fix electrolyte problems like low sodium or potassium, manage acid-base imbalances, and just support their circulation. Plasma transfusions are often given, especially if they have FPT or low blood protein levels, and nutritional support is paramount for healing. If they can't or won't nurse effectively, they need nutrition via nasogastric tube or sometimes even parenteral nutrition, TPN, given intravenously. They need a lot of calories, equivalent to 10–25% of their body weight in milk daily.
And the general nursing.
Meticulous nursing care makes a huge difference, keeping them warm, clean, dry, in a well-ventilated space. If they're recumbent, lying down, they need to be turned frequently, maybe every 2 hours, to prevent pressure sores. Keeping them propped up on their sternum helps their lungs expand. It's intensive, round-the-clock care, really.
It sounds incredibly intensive. Are there any newer, maybe experimental therapies being explored?
There are. One area getting some attention is called metabolic resuscitation. This involves using a combination of things like low-dose hydrocortisone, thiamine, and vitamin C. The idea isn't to directly kill bacteria, but to try and modulate the foal's own overwhelming inflammatory and metabolic response to the infection, hoping to reduce organ damage and improve overall outcomes. Still under investigation, but interesting.
Looking down the road then, prognosis. What factors really swing the odds for survival?
Several things really impact survival chances. Factors that tend to worsen the prognosis include having multiple joints infected, having concurrent osteomyelitis, that bone infection is a big negative factor, or having gram-negative bacteria or a mix of bacteria involved. Also, finding a high percentage of those degenerate neutrophils in the joint fluid we talked about, having other concurrent diseases like pneumonia or severe diarrhea, being very young, say under 30 days, when diagnosed. These all make it tougher. On the positive side, starting treatment very early, within 24 hours of signs appearing, and using multiple treatment approaches, systemic antibiotics, local therapy, lavage, that combination approach improves odds.
And what are the actual survival rates? You mentioned they vary.
They do vary quite a bit in studies. For septic foals overall, survival might range anywhere from, say, 26% up to maybe 86%, but most studies land somewhere in the middle, around 45 to 60%. For foals specifically with septic arthritis, the survival rates reported are generally better, often in the 78 to 89% range. So most foals with septic arthritis survive the initial infection.
That sounds pretty good, survival-wise. But does survival mean they go on to be sound athletic horses?
That's the crucial distinction. While survival rates are relatively okay, septic arthritis can definitely limit future athletic potential even if they survive. We know these foals often take much longer to start training or racing compared to unaffected foals. And interestingly, it seems to be the number of joints involved, not necessarily bone involvement, that correlates more strongly with a poor racing prognosis. Long-term soundness really hinges on whether that joint cartilage was permanently damaged before the infection was cleared. If there's significant cartilage loss, arthritis is likely down the road.
And the economics play a big role in prognosis too, don't they? The cost versus the potential outcome.
Absolutely. Treatment is expensive. Very expensive. Prolonged hospitalization, multiple procedures, intensive care. The cost can become prohibitive for some owners. And sadly, that sometimes leads to the difficult decision of euthanasia, purely for economic reasons. Plus, the potential loss of future value as an athlete, especially for a well-bred foal, weighs heavily in those prognostic discussions. It's a tough reality of the situation.
Given how devastating this can be, prevention seems paramount. How do we build that shield? What are the most essential prevention strategies?
Prevention is absolutely key, and it really needs a multi-pronged attack. There's no single magic bullet. But if there's one thing that stands out, it's colostrum management, preventing failure of passive transfer. That is the most critical step. Foals have no immunity at birth. They need that antibody-rich first milk. So ensuring they get enough good quality colostrum, ideally within the first 6 to 12 hours, is vital before their gut closes to absorbing those large antibody molecules.
How do you know if the colostrum is good quality?
You can test it easily with a simple device called a colostrometer or a Brix refractometer. Looking for a specific gravity over 1.060 or a Brix reading over about 23%. If the foal doesn't get enough or the quality is poor, you need to supplement. Give them banked, frozen colostrum from another mare or administer commercial equine plasma intravenously to get those IgG levels up over that 800 mg/dL threshold.
And that umbilical care, treating it like the open wound it is.
Exactly. That umbilical stump needs meticulous care. Let it break naturally, don't cut it short unless necessary. Then treat the stump with a suitable disinfectant 1% iodine or 0.5% chlorhexidine solution. Works well several times a day, maybe 2 to 4 times, until it's completely dry and shriveled. Avoid handling it unnecessarily or using harsh treatments that could cause irritation.
What about the foal's living space, the environment?
Biosecurity and environmental management are huge. A clean, dry foaling stall or a clean pasture area is essential. Prompt manure removal is really important, especially on farms with multiple foals, to reduce the load of pathogens like rhodococcus and salmonella. Dust control can also help. Avoiding overcrowding is key. High stocking density just increases the risk of disease transmission. Basic biosecurity like isolating sick animals, strict hand washing or using gloves between foals, designated equipment. It all adds up. And quarantining any new horses arriving on the farm is always good practice.
Can vaccinating the mare help protect the foal?
Yes, vaccinating the mare is another important layer. While there isn't a licensed R-equa vaccine widely available in North America, giving hyperimmune plasma against R-equa to foals on endemic farms is common. But mares can be vaccinated against other things like salmonella or rotavirus. Vaccinating the mare in late pregnancy boosts the antibody levels in her colostrum. So the foal gets a higher dose of specific protection right from the start. It maximizes that passive transfer effect.
And finally, being vigilant, catching problems early before they escalate.
That's the last piece of the puzzle. Early detection and screening. Being proactive. This means regular, careful physical exams. Observing foals closely every day for subtle changes in attitude or nursing. And that twice-daily palpation of all joints we talked about. Monitoring temperature, even though it can be variable. Using screening blood tests like CBCs and especially SIA levels can pick up inflammation very early, even before obvious clinical signs. And on some farms, routine ultrasound screening of the lungs for early IR equine pneumonia or the umbilicus for internal infection is done. These things help identify at-risk foals sooner, allowing for quicker intervention if problems arise. It's all about vigilance.
This has been a really thorough deep dive. It certainly underscores the complexity of neonatal full septic arthritis and septicemia and just how critical that early, aggressive, multifaceted treatment is. It really is a race against the clock for that foal's future.
It absolutely is. And it also highlights those ongoing challenges we face, particularly antimicrobial resistance. It reinforces how crucial it is that we use antibiotics judiciously based on evidence to make sure these life-saving drugs remain effective for future foals.
Definitely. So, to leave our listeners with something to think about, considering the huge impact of those early environmental factors and the mare's health on the foal's developing immune system, what unexpected parallels might you draw between building resilience in these vulnerable foals and maybe building foundational health in other vulnerable populations, whether they're human or animal?